Okay, right, ladies and gentlemen, I think we're ready. Lamb, be quiet. You're on the naughty step. Well, we're going to kind of culminate the day now in a conversation that I hope is going to end on an optimistic note. And now, if you've come to watch this panel with something that's written in the programme, it's not what we're going to be talking about. I forget what is in the programme now, but what we actually are going to talk about was leading on from what you led us into in the last session, and that is there is so much good stuff out there, but why the bloody hell doesn't the NHS use it? That was what I wanted in the programme, but they wouldn't put it in, so they put some other bullshit in. But so that's really what we're going to talk about. Why doesn't it happen? Now, I'm going to let our panelists introduce themselves and tell them where they come from and what they do. I'm then going to come back and ask you for a sort of a kind of an overview of where you think we are on this, and then we'll have a discussion, and all these very bright, intelligent, good-looking audience will pepper you with impossible questions that you won't be able to answer, but we'll have a go. Right, off you go, John.
Hello, my name's John Wilkes. I have the privilege of being the custodian of leadership of the Institute of Health and Social Care Management. The Institute goes back to 1902, but today it's important that it's health and social care management. More about that in a minute. But I'm really here to represent the views of our 8,500 members across the country in respect of their experience of technology and making it stick.
Thanks, John. Hello, my name's David Kuo. I'm also a fellow of the Institute of Health and Social Care, and very proud one at that. I've got, although I've got an American accent, I've been in the UK for 39 years, and all that time working in health IT. I'm an ex-CIO, ex-board level member of various trusts, and my focus is on integrated care and how to use digital to further the objectives of integrated care.
Hi everyone, I'm Jasmeet Rai. I'm a former Associate Director at RCH Care Homes, which is a medium-sized care provider in the South East and East of England. So I was an Associate Director there for 5 years. Also a fellow, thank you John, at the Institute. And that's partially because I'm one of the co-chairs of the People Plan for Social Care, which was the first and the second entirely grassroots-led consultation with the social care sector on the reform and change that's required. I'm currently a freelance consultant.
Thank you. My name is Liz Ashall Payne, and I wear a couple of hats. I am the founding chief exec at ORCHA. ORCHA is an organisation that is obsessed with getting high-quality technologies into the hands of people who need them. And the way in which we do that is through two big areas. One is we assure products against quality compliance requirements like DTAC and evidence. And second of all, through distribution channels, so prescription infrastructure, but now for digital health technologies. The other hats that I wear predominantly are at Tech UK. So I am Vice Chair on the Health and Social Care Council, and I'm also a Director of the Tech UK board leading on SMEs and clinical by background.
Good, thank you. So we've got the, thank you, is that me or you? Sorry. Oh, we've got the IHM family here and some real experts. I mean, if you think about it, we've got the whole spread here. We've got an organisation representing the hospitals and primary care and what have you. We've got an expert in David on trying to do stuff in trusts. We've got social care, and we've got all these dinky new apps that everybody keeps inventing and nobody uses. So, right, give us your, let's start. You've got the microphone, David. Give us your overview of where you think we are.
Okay, so...
Strap yourself.
Yeah, look.
You may not like this.
I don't think it's the cheeriest of stories from my perspective, but in my little corner, I've been working very hard for many, many years in the NHS to implement large-scale, digitally enabled transformations. That's usually in the form of implementing these, large electronic patient record systems you've heard a lot about. They go under the name of Cerner, Meditech, System C, Epic, etc. So I've spent a lot of my life and earned a lot of scars trying to put these into large, often very large hospitals. To be honest, with mixed success. And why? And so I think today's question here is, why aren't these implementations or investments always successful? And I would maybe quickly say, I think a lot of it is leadership, unfortunately, and maybe we can discuss what we mean by leadership, but I would, from my corner, I've seen a lot of variability in leadership in the NHS, not for want of trying or dedication, but maybe lack of experience, lack of stick-withedness, persistence, and maybe too much regime change, too much turnover of leadership.
Just before we pass on, I mean, can you explain to me why it takes 6 months to implement Epic?
To what?
Why does it take 6 months to implement Epic?
I'm not aware that it does take 6 months to implement Epic. In my experience, it's usually around 18 months.
Why does it take 18 months to implement Epic?
Well, because it's a lot faster than implementing some of its main competitors' products. So,
there is a subtext here, isn't
there? One way to quickly and simply answer your question is, the smaller the system, the faster the implementation. If you have a medium size or a large system, it's going to take longer. So let me just give you some numbers. If you implement a system like Epic, say, you will tend to implement, and this is borne out in experience in the UK, between 40 to 45 different modules. If you implement Cerner in the UK, you will tend to implement 20 to 25 modules. If you implement System C, for instance, in the UK, you will tend to implement between 10 and 15. Okay, so, and the amount of time it takes to implement these three systems as examples are, correlative.
Okay, thank you. Let's come to you, Jasmeet. Now, you're sort of in the on the periphery of social care and care homes and so on. Tell us about the interface between social care, home care homes, the NHS. I just this morning before I came here, I was on the radio, the BBC, talking about you'd never believe this, but there were two elderly ladies with the same name. Right? That's not unusual in the NHS. 60 million people, you're going to get people with the same name. One of these old ladies died, very sadly. The other old lady was in a care home and died. The other one was one of them died. Doesn't matter where they were. Anyway, the one that had died, their relatives were phoned up by the NHS and said that she should go in for an appointment or whatever it was, and they said, well, she's died. And so there was a muddle over the patient's notes. Now, there's 2 points of identification with all patients. What's your name, what's your date of birth? For operations, there's what's your name, what's your date of birth, what's your NHS number. So all the treatment was right, but the notes all got muddled up somehow or other in the passage between the hospital, the care home, and the woman's home itself. Is that common? I mean, what are the interfaces like? What is the relationship between you and every other part of the system?
So I think I'm going to make a lot of people unhappy in this room when I say this, but the interfaces aren't great. The ICBs, I know they are meant to be for healthcare and social care. When we did the people plan consultation last year and the year before, I'd say a handful of care providers had their ICB contact them. They knew who their ICB was. A pet peeve of everyone in social care is that you have the daily capacity tracker, that as care providers, you are required and mandated by law that you have to update on a daily basis with your capacity to admit new residents. From the NHS side, on the other hand, what you have is you speak to discharge teams, they don't look at the daily capacity tracker, they don't know that it exists, and sometimes they don't really care that it exists either. So those are just two examples of how you've got two systems which are basically two pillars that prop each other up. If you don't have the NHS, you don't have social care. If you don't have social care, you don't have the NHS. And they definitely need to get better at working together. What I will say, though, that there is a lot of innovation in social care, and there are a lot of people who are no longer willing to wait for the government to sort out the problems for them. They want to try and make the change happen themselves.
So give us a couple of examples. Give us an example of the kind of thing where people do sort themselves out, because people do sort themselves out, don't they? You know, we've got a pen and paper system in large parts of the NHS, so they get bigger bits of paper and another pen. I mean, give us some thoughts on how that works.
Okay, a big one is sustainability, and it is linked to digitisation as well. So the NHS has had a net zero plan for the last 10, 12 years. Social care, despite being a sector that employs a larger workforce and having more patients or residents that they support, doesn't have a net zero plan. It doesn't have anything really. It's individual care providers who are saying, I know that decarbonisation is going to be important in the next 5 years, just the way that digitisation was the buzzword for the last 5 to 10. Decarbonisation will be the buzzword for the next 5 to 10 years. And they are building their own sustainability alliances. They're building their own workshops, their seminars, and they're pushing them out to providers to provide that support to each other that they're not currently getting elsewhere. And that's where the tech part comes in. COVID and the entire pandemic showed us that you can do a lot of things remotely, and a lot of people work together as a result. So now you've got people from up in Newcastle working with care providers down in Cornwall on the same projects, and that's amazing.
Okay, Liz. So you're, you have a broader interest, but your interest is fundamentally about apps and people developing apps, and they, you know, anybody with a bobble hat and a shed can make an app, but is it safe? And there are various, people may not know, there are various classes of app, and if they are measuring, for example, your blood pressure, it's a class, whatever, it's class 2, yes, it's not invasive. But if you get the blood pressure wrong, you could kill somebody, so it has to have an approval. So there are various hierarchies of how these apps work. It's not just a case of making an app. Now, you approve that. You work with NHS England, and you make stuff safe. And all. Now, you must have a huge backlog of fantastic safe stuff that somehow or other can't find its way into the system.
Yeah, so just a few points. So we work with the NHS more at ICB and organisational level rather than nationally. But what we want to find are the great technologies. So there's about 350,000 digital health apps, and that includes web-based tools as well.
Say that again?
350,000.
350,000. Anybody in app development here? Put your hand up. Okay, well, we've got 6 of the 350,000.
Exactly, and I bet some of them may have made more than one. But yeah, so there's lots and lots of technologies out there, and one of the challenges that everybody in this room who's creating products will find is being able to lift your head above the parapet and be found amongst some of the not so great technologies out there. So we've run about 30,000 assessments to date. And of those 30,000 assessments, only 20% have been found to be safe and effective. Now, why should we care? Well, we should care, first of all, because every day 5 million people will download a health app. And most of the technology...
Hang on.
Yeah,
these are take-home statistics. 5
million every day. And most people will therefore be finding unsafe, non-effective tools, which means for technology suppliers who are wanting to build something that's safe and effective and robust, they can't find a route to market. And that's a problem as well from an economic perspective. because it's these smaller companies that we're really putting the weight behind. Rishi Sunak talks about technology being our future economy, but if they can't be found and funded, then how do we grow the economy? Now then, when you look at the NHS, what's going on there? Well, I mean, so far what we've talked about is technology infrastructure. So that is electronic health records. For me, that is completely different to these technologies that I'm describing. These technologies I'm describing are patient-facing interventions. And policy...
I'm going to interrupt you there, because these are the kind of stuff that we've all got on our phones. We all have apps for all kinds of different stuff. And I've got an app from the NHS app. All I can do is repeat prescriptions and have a look at a summary of my healthcare record that I've looked at once and thought, well, why am I looking at this? It's of no interest to me at all. So where are they going to channel in via the NHS app?
So,
I mean, how's it going to work?
That would be a vision that I would be pushing, which would say that the NHS app is incredible because it holds your information. However, as of today, all the people who have the NHS app on their phone are probably living with a condition or maybe waiting for an intervention. So I'll give you a personal example. I live with type 1 diabetes. My NHS app knows that. It knows that I take insulin. It also knows that I'm on HRT and going through the menopause. Well, there are products that could help me manage my conditions. And of course, if it knows that, then it could pick the safe technologies and immediately promote them to me in a bespoke manner. Now, for me, I think that's a vision that we should be getting behind. And I have been fortunate enough to speak to a range of people, and I think that could be the vision. So I will keep pushing for that vision to be realised.
And you weren't in here earlier, but
I know Wendy very well.
I'll just get you to repeat it, because the other bits, I'm coming to you back in a minute, David. I haven't forgotten, because the other panelists won't have heard. Just briefly repeat what you said in the previous session.
Well, my question. Well, the question I asked to the last panel was, are there actually any success stories, and is there reason to be optimistic?
And talk about your product quickly.
So Liz knows my product. We're on the ORCHA directory. We've got no, that's fine. Perinatal pelvic health. So we're Muti system. It's an exercise program. It's a web app, evidence-based for core and pelvic floor health for all mothers.
Which is a huge issue. It's not just some little unique thing that some women have a bother with. It's a huge, and you've only got to look at the adverts on daytime television and the products they're advertising to see that it is a big issue. David, you wanted to come back, and then I'll come to you, John, for your overview.
Thanks, Roy. Sorry, I just had a point of clarification. Liz, so you said a huge number of these apps out there are not deemed to be effective, but I think you also said unsafe. But for me, something that's not proven is not necessarily unsafe.
Absolutely. So,
is that true?
So when we discredit the viability of a product, it may be around its data security, data privacy, clinical professional assurance, which could include safety or effectiveness. But all of those elements are critical. And what I'm saying is that only 20% of technologies out there meet the quality criteria in aggregation. But you're absolutely correct.
Those that haven't met it aren't necessarily unsafe. They could be.
Well, I think if something is
well,
sharing...
it's the risk. I mean, Joe Harrison is the guy that's doing the NHS app thing. And I was talking to him, and you could put an app via your NHS app, which could be a backdoor for a bad actor to come in either to your system or into the NHS system. So that's why there is this closed loop. Anyway, let me just carry on with the original question, John. You speak for 8,000 NHS managers. You have an extremely strong data group, an IT group. What give us a sense of the feeling in that group.
There's a film from the 1970s called Man of La Mancha, and stay with me here. It involves Peter O'Toole, a knight, trying to explain to a smoulderingly beautiful Sophia Loren why he's not allowed to kind of develop a relationship with her. And he sings a song called The Impossible Dream. And the opening lyrics of that are to dream the impossible dream, to fight the unbeatable foe, to bear the unbearable sorrow, and to run where the brave dare not go. And Roy, in answer to your question, the feeling of my members is we have a leadership within health and social care that looks at technology in the same way that Sophia Loren is looking heartbrokenly back at Peter O'Toole, because he's just too bound up in his sense of duty to be able to just say, I don't care whether this is right or wrong, this is my decision, and you and I are going to get married, Sophia. Words to that effect. Do you get the idea here? They're just so terrified in leadership positions of taking a decision and seeing a project through properly to a measurable outcome, so that we can then adjust it if necessary and maybe do it differently or edit it or something like that. It's this terror of just getting on with it. Take a decision, do what you know is right, and we will all rally around and help you. We just have a leadership crisis about behaving like that.
That's a very interesting thing. And I mean, David, if I could come to you. I mean, we've just spent £383 million on a federated data platform. Okay, somebody somewhere decided that that was what they were going to do, and we've paid for it, and there you are. Hang on.
But how long has that decision taken?
Well, actually,
You know,
with
it's
Palantir,
forever.
it was, yeah, we won't go there. But the point I'm coming to is there are also half a dozen other companies here that are already doing federated data platforms. Veror, for example, is one, and there are one or two others as well. So what was the point of the NHS spending 383 million on something that they have no power to insist that trusts use? I mean, they can put their, you can put the chairman's arm up his back and say to him, you're not going to get your nigh to it if you don't do what I tell you. But I mean, there's no real way that, there's no real way of making them do that.
Roy, are you asking me? I absolutely agree. I think that, so what's the point? If, by the way, I don't know if you've read, but if you haven't, I encourage you all to read Steve Black's piece in the HSJ yesterday, where he addressed that very question. What was the point of this £330 million investment? Because he argues that actually the problem with this is not cost or security. He says, you know, £70 million a year, that's, he calculated that's 0.04% of the annual NHS budget. So it's not really the cost that's a big objection, nor is it the privacy thing, because Palantir isn't promising to take it anywhere, it's just processing the data. So it's not really, but his main point is that it's based on a set of probably quite invalid expectations of the benefits it will produce. And he interestingly quoted something which I hadn't heard of called the Anna Karenina principle, which he said, you know, because Tolstoy said that, in quote, all happy families around the world are alike, but all unhappy families around the world are unhappy in their own way. And what he means by that is this new federated data platform is dependent on getting data from all of these different acute trusts, not primary care, by the way, but acute trusts, who have to give data, for instance, to support waiting list management. And they all do it, in Steve Black's terms, in an operational omnishambles. They all do it differently. Okay, so therefore, you know, data around waiting lists is very fragmented. all across NHS trusts, and it's that fragmented data that now we're supposed to use in this new federated data platform to improve waiting list management. How is that going to happen?
I don't know. Jasmeet, I don't know if you're across the federated data platform, but yeah, you may be relieved or disappointed to know that social care is not involved in this.
Nor is primary care.
Are we surprised at that?
Well, no, the reason they're not involved in primary care is that no one wants to take the BMA on and make the GPs open up the back doors of their records.
No, it's just clarifying that federated data is the new Palantir contract that everyone's been talking about.
Yeah, but social care isn't involved.
No, it is not. Okay, with social care.
But could it be involved? Does social care, in its global meaning, does it have enough digitized stuff to be able to suck it into a big system like that?
I think social care has a real dichotomy in the digitization aspect. So you have got one end of the spectrum where they're doing incredible innovative things. You've got a care home which has got VR headsets and motor tech bikes for residents who are living with dementia. And in that same care home, you also have fax machines because the NHS still needed to use fax machines up until I think it was a year ago. So you have a real spectrum, and the same with any other sector. You are going to have some people who are tech literate and are early adopters, and you're going to have other people who are more tech averse. And essentially, whether it's healthcare or social care, it comes down to change management. How do you bring everyone on that journey along with you? There is definitely an appetite within the social care sector as a whole for there to be integrated care records of some sort, because it would reduce the sheer amount of duplication of patient records and work that comes across. So for example, there are many instances where a resident will be admitted into a hospital. They will take their patient history, and when I'm talking about patient history, I'm talking about like their personal life history as well. So not just like their physiological medical conditions, but also, what are their likes, their dislikes, their hobbies, favorite foods, all that kind of stuff. And then when they are admitted into a care home, or as they're discharged to a home care provider, they're asked to provide that same information again. And for someone who's navigating the social care sector, you're normally navigating it at a point when you need it. You don't go out to social care to go buy something like the way you'd go buy a new car or like a new TV. You do it because you're normally at a crisis point. So if we're talking about digitization and integration, I think one of the best ways for that integration to occur is the care journey, not just have isolated silos.
John, did you want to come back?
Yeah, the other point I would make is that we don't know about what social care has. We have no audit nationally of their hardware. We have no audit nationally of their software systems, so we just don't know. I might add, I'm not sure we've got a national audit of hardware and software across the acute sector either, or mental health or charity sector. If it had been me, I'm very fond of a phrase that you are regularly using, Roy. Start from the patient and work backwards. And it strikes me that we have manifestly failed to do that over many, many years now.
That's a good point. Actually, David, do you know if social care have a maturity index for their IT systems? Because we have a maturity index, and HIMSS had a fantastic maturity index that they wanted to sell to the NHS England, and NHS England said, this is a really good idea, we're going to do it ourselves. And so it put us back 5 years whilst they did the maturity index. What have they got in social care? Do you know?
I'm not aware of one.
No, I don't think there is. Does anybody know? I don't think there is, no.
I don't think there is, but I think you also need to remember social care providers, 80% of the market are SMEs.
Yes.
Right? So they are tiny little providers, often where it's one care home or one domiciliary care provider office, and they are cash poor, but they are also time poor. So they will... The beauty of healthcare and social care is that so many people who work in those sectors are people who genuinely care about the patients and the residents. And so if you give them a bit of technology which you're like, this will help improve your patient outcomes, your resident outcomes, improve their quality of life, they are normally going to be really excited about that. If you say, I can give you a technology that's going to improve your admin system at the back and make it easier for you to print your records, they probably don't care about it as much, but that one is going to be just as vital and as important in the overall running of everything.
I just want to go to Liz, and then I'll go back to David.
I think one of the things that I see when we talk about maturity of technology within health or social care, again, we're not talking about patient-facing interventions. We're talking about electronic health records. And we have to move the conversation on.
Yeah.
So the point that you're talking about is you're trying to impact people and patients' lives. The EHR doesn't really do that. And evidence is coming out more and more to show that it doesn't, whereas all the interventions that are patient-facing, people-facing, we've got to move the agenda on. So if you're HIMSS level 7, you may never have touched a patient with technology, but you can still be HIMSS level 7.
That's a really good point. David, did you want to come back?
Well, I wanted to make a suggestion, listening to Liz and the assessments that you do of apps. So I absolutely think those type of safety assessments should be applied to electronic health records. Yeah. Because, so for instance, we've had these shared care record things for some time. There's one in every ICS. It's a big repository of data. But the problem, in my view, with that, and also with the federated data platform, and actually with EHRs, is no one's measuring data quality. Okay, it's a real bugbear of mine. John knows, but I absolutely believe that each of these systems, any system that holds patient records like drug records, needs to be measured and overseen and governed by agreed data quality metrics, which don't exist today, for accuracy, completeness, relevance, and timeliness. These are the agreed factors, variables for measuring data quality, but none of this is being applied to these systems with sensitive patient data.
And it moves us on really as well to okay, so we've got shed loads of data, literally, and we've got no one to analyse it. They're as rare as hen's teeth trying to get people to come in and analyse data. Right, if you've got a question, just put your hand up. The panel, I'm sure, will be pleased to answer it. There's a gentleman at the back here. Right, sir. Okay, I'm going to hold the microphone. You're going to speak. Here we go.
Cross-infection policy, that's good. Is there any point in trying to introduce digital solutions to trusts when they are about to or are implementing or are just bedding in an electronic patient record system?
That's a very good question, because he's talking about 20% of the market.
Oh, I see.
Yeah?
Yes.
Is there any point?
You go ahead.
Yeah, I'll go first. I think my experience when you're talking about patient-facing digital health technologies is you don't want to talk to the people who are running the EHRs anyway. You want to be talking to your clinical and medical leaders. They're the people who will really get what you're doing. So where do you get the funding? Well, you don't get it from the technology pot, you get it from the clinical and medical pots. So elective recovery pathway funds, maternity funds, because these are our new medications. And so I would say, yes, you do, but the people you talk to are not the people working on EHRs.
And it does also mean that you as a supplier will need to write the business case.
100%.
Yeah. You've got, as well as designing great products, you've got to have a really good business case for it. I think you wanted to say...
I guess I would just add to try and answer your question. So I absolutely agree. Get to the clinicians first, because then you have a driver in the organization who says, yes, this is a good thing, we need it. But often trusts have a bit of a complicated governance layer, so that the IT department who are putting in the EHR, yes, you're right, they will tend to say, no, we're too busy putting this thing in. However, the more mature and sophisticated ones will get that actually they need both. Okay, they will understand, particularly the ones that have put it in and it's been stabilized for a while. So no, you don't really want to go near them when they're putting it in. It's chaos. But a lot of them have already put them in. So get into the more mature ones will get that actually they need to have quite a complex ecosystem of core EPR platform and new innovative technologies that come along all the time. They need to be able to plug those in.
And I think Liz made a point earlier. I don't know if it kind of went over your heads, but she said apps are the new medicines. So if you think about how you would introduce a medicine into the NHS, you would go and talk to the clinicians. If you were going to introduce a new prosthesis for a hip, for example, you would go and talk to the surgeons. And she's absolutely right. The way in is to think like that. We have to change the way we think about our products. Was there another? Yes, I thought I saw another hand up. Hang on, I'll be right back, sir. Yes, ma'am.
Having been in the NHS in the past and heard about accountable care partnerships at that time and now ICBs and ICSs, the question is there a fear regarding the integratability or interoperability?
A fear?
Of introducing any technology into the...
Do you mean a fear of the interoperability and its effect, or the fear of not having it? Yeah, I mean, we absolutely damn well should have it, is the answer. But let's see what the experts say. John, off you go.
Well, I'm not sure I'm an expert, but I'll present the views of our members, and I hope Jazz will agree with me here. We've got 42 integrated care boards. How many of them have developed a properly discussed and developed digital technology plan for how they're going to make the lives of their citizens across their regions more comfortable, happy, fulfilled, healthy, fit, whatever it might be? And my suggestion to you is none. They just haven't done it. They've been led by predominantly acute hospital-based directors and CEOs. I think probably deliberately set up that way, if I could be contentious for a moment. Most of them are underfunded. They're already staring down the pipe of further cuts and so on. And it strikes me they just simply have not taken the opportunity, once they were set up, to sort of do town hall meetings and engage with their citizens and figure out where the fault lines are based on real lived experience, and then get social care, mental health, tertiary sector, acute sector, proper representatives together. I don't mean all the directors, I mean proper people who've got a view and a worked experience. Get everybody together and say, right, we've got a golden opportunity here, once in a generation opportunity. Now these things have been set up. Let's take control of our own destiny. And they haven't done it. And I'm really disappointed. By the way, you know, if your mother says to you that she's really disappointed, you know what I mean.
Yeah. David, talk to us about, I mean, John's absolutely right. I'm sure they haven't. Because they're not new kids on the block, really. They're just another kid on the block. And they've inherited all the crapola from the previous organisation that was doing pretty much what they were doing. In terms of interoperability, is it a pipe dream, really? Do we need it now? Because you can mutualise access, can't you, with data? You don't really need to rewrite every data platform so that it's actually interoperable. I mean, there are ways around it now, aren't there?
We are still, I would suggest we are still in the Stone Age or thereabouts. I mean, yes, there are tools and there are standards. You know, there's FHIR, which is fast becoming a global standard in terms of, you know, a common data format for holding data. And so there are tools, but the problem is that, there aren't enough. There aren't enough strategies, there aren't enough leaders willing to deliver the strategy. Maybe there isn't even enough resource or talent on the ground to be able to do it, even if there was leadership. But it's a complicated equation. It's not just about the technology. I would suggest the technology is the least of the issue. Yeah. It's about plan, vision, determination, talent, workforce and culture.
Yeah, I mean, we talked about Palantir earlier, and you'll all have a view on Palantir and whether they're a good company or a bad company. But the fact of the matter is, during COVID, my doctor's in Surrey. I was living in London. I was able to walk into the Excel Centre one morning, give them my name, my date of birth. Young lady on an iPad said, "Oh yes," told me who the practice was, gave me my NHS number, gave me a jab. I had my COVID jab, and within, I think, 48 hours, the fact I'd had my jab was on my NHS app. It can be done, because that was a massive piece of software writing and interoperability with goodness knows how many 8,000 GP practices up and down the country. I mean, it can be done.
Can I come in?
Yes,
Because
please, yeah.
I want to, you said that Roy says all the time, let's start with the patient in mind. And I just want to take one step away from the patient and talk about the clinician. So when I was working clinically, I always wanted to be able to see the data about my patient's health and be able to risk stratify on a day-to-day basis. This was the vision, so that I could bring in the people who needed to be seen, rather than seeing the people who were booked in, most of whom who didn't need to be seen. So what are the barriers to us doing that? Well, the first thing is that the electronic healthcare records are not set up to receive this tsunami of data. So I shared with you that I use digital health technologies to manage my diabetes and monitor my menopausal symptoms. If I wanted to share that data, an electronic health record can't receive it. And I'm going to give you an example. Apple Health Kit, about 3 years ago, shared the data with EMIS so that primary care physicians could look at patients' health data. Guess how many people ever looked at that data? 0. Why? 1, it was a vomit of data, so it wasn't structured, so it made no sense. But second of all, doctors were nervous about looking at it, because if they looked at it and missed something, they've opened a duty of care, and that's introduced a risk. And so to your point, the technology piece is easy, but we have to build confidence in how we can use this data from a patient perspective and really understand what the benefit is to sharing the data. And I don't think people are thinking pragmatically enough.
I'm not sure we got to the heart of the question about interoperability. And I'm not sure I'm clear whether or not we've gone past the interoperability piece and now we're looking for something else. Is that right? Where are we on it? I'm still don't know.
I think so. Interoperability, I would say 2 things. One is from the perspective of, let's say, the perspective of the clinician, or actually even more than that, the care team around the patient. Okay, so the social care workers, the GP, and the hospital consultants, say. Okay. Let's talk about interoperability in that use case, in that scenario. In that scenario, you would want, for the sake of the patient, for all of those caregivers to be sharing the same single patient record, okay, from a kind of conceptual interoperability point of view. Because you'd want only one record of my medications, you don't want multiple. And my appointments and so forth, and my history. So from that point of view, there are technology solutions out there to deliver that scenario, okay? So for instance, in Northern Ireland, I was just saying to Jazz, that in Northern Ireland, it is the case that they have a national, all across Northern Ireland, digital plan to deploy one EPR system across acute, community, and social care. Okay, so they've already crossed an important bridge there in Northern Ireland. So to that extent, Northern Ireland will be solving the interoperability picture from that perspective. Okay, there's another perspective, which is slightly more, maybe more pragmatic and realistic for the rest of the world in like England, where there isn't going to be, in the near future, one single system across care settings, although there is one ICS that is planning to do that. I'll tell you what that is later. But for the most of us, so their interoperability, which is exchanging information and data between different computer systems, that's where interoperability is really important. Where are we on that? The standards are there to deliver it. I think, again, it's not so much a technology issue, but it is an issue around the barriers are around getting the marketplace to want to buy it, getting the suppliers to want to adapt their systems. It's a multifaceted project management problem in each area. Okay, but it needs to be led by leaders, for instance,
Yes.
ICSs or, but that's not happening.
Well, it isn't, because there are standards, aren't there? Is it the Bristol standards, or somewhere there's a place name standards that all the IT guys got together and they said, this is what the interoperability standards are going to be. And then I forget where was it? Exeter
Yes,
standard.
but that was
Yeah.
for a certain clinical area. It wasn't for every,
No,
yeah.
there was all the IT people got together a while ago now, and they said this is what interoperability looks like. And then the industry got together and said yes, and they come up with their own interoperability standards. So we still got no further forward. Okay, listen, I don't think we've added much to the, but I mean, it is important, isn't it? It is madness that we're still buying stuff that doesn't speak to the other stuff. Why would you do it? Well, it's because procurement isn't very good in the NHS, and because every trust in law is independent and allowed to buy its own stuff. And we don't crack the whip centrally on procurement and say, you will not buy that, you're going to buy this. And they won't do that for some reason, because they think it's going to take away the freedom of trust to make their own choices. Right. You move us on, sir. Where are we going?
Well, okay, I'll allow you to hold it, but I have two parts to my question. I hope you won't take the microphone away.
We've only got the room till 9 o'clock.
So I'll channel my 17 years of NHS policy, although I now work in the private sector in the tech company. 6-7 months ago, the DHSE made an announcement, Lord Macron, talking about 225 million being made available for digital therapeutics on mental health and MSK. Equally, you have every ICS, or most ICSs, as you pointed out, having a digital strategy with all sorts of wonderful priorities in there. The first ever such digital strategies. I suspect that we won't see the money happen on digital therapeutics, and we won't see the ICSs achieving more than half of those priority areas. What are your views, or where will we be in 2 years from now?
Thank you. I mean, we know, don't we? Because NHS England have already said, do not spend any money on IT. They've done it because the government have reined back on the expenditure. They still have to hit the waiting list targets, and they don't have the money, so the IT expenditure has been stopped. Liz, I think you...
I'm happy. Yeah, I mean, I'm happy to. I'm just aware that I don't want to hog the
No,
floor.
don't worry. We're going to come to Jazz, and she can tell us that social care don't have any money either. But go on, yeah.
So I think it's a real problem. And it's a problem that I think people feel a little bit embarrassed to talk about, which is who pays for this stuff. And we shouldn't be. You know, I used the analogy earlier that these technologies are our new drugs. We pay for drugs, but we do that in a very systematic way where we know which drugs are safe and effective for which people, and then we have a workforce that is ready to receive the drugs and have an infrastructure to prescribe and reimburse. It's not rocket science to do the same for digital health technologies. And I think it's really sad that this money is being pulled for two big reasons. One, because those technology providers will not feel confident in staying in this marketplace. And what that means is that we will lose the jobs that are currently in this economy. We're in an economic crisis. Second of all, when those companies leave, they take the technology with them, which means that as patients, we don't have access to those amazing innovations. And of course, it becomes a downward cycle where investors then get nervous about investing in this economy. So I think it's really sad. I am genuinely hoping that this turns around because, of course, as I said earlier, Rishi Sunak is pushing technology, particularly in life sciences, as the future for the economy. So something has to change.
Do you really think it will? I mean, the funding to all public services is being cut so that Jeremy Hunt could do tax breaks for business, which we understand because he wants the economy to grow. That's their long-term strategy. Keir Starmer has already said, don't come to me for more money. It looks like they're going to adopt the Tory spending cycle very much like Tony Blair did when he first came in 1997. So, these are entrepreneurs. These are people who want to sell stuff to the NHS. But the most important thing is that they don't walk away from here today with some bullshit idea that it's easy, it's not, or it's going to happen anytime soon, because it won't, and the market will pick up, because it's not going to. I mean, we have to be, I think, if they're going to have a take-home message that's valuable and important from people who are actually out there doing it, they have to really understand where it's at and where it's going. David, I'm looking to wrap up now. If you would give me your answer to that and your concluding thoughts, and I'll come to the rest of you.
Yep. So I will try and leave an upbeat note on what you just said, because
I was going to slash my wrist. But
yeah. So I have actually worked, and I am working with some, let's say, more mature and enlightened trusts, who, even within the current financial climate, believe that their investment in their EPR system is their way out of their financial problems, because, you know, they just have to get over all of the inefficiencies that have built up over the years, and they see this digital tool as the only way of getting around it. So I think that to me is very encouraging. I mean, I am also working with other trusts who say, absolutely, you know, it's all, you know, no more spend on IT. So there is a change. And the other slightly up, you know, maybe other upbeat thing I would say is I've actually met one of the, Canadian companies here over the past few days, who have, I think, a product which I think is going to be extremely helpful on the interoperability front that was raised before. A company called Smile. They've got a technology which I liken to like a circuit board, which, you know, allows data from different sources to be ingested and redirected in a standardized format to other sources. And I think that's the sort of tool that NHS trusts could really use. The challenge, which I think is overcomable, is to build a business case to show that investment in this type of product will pay for itself over time.
So there's still room in the market for the right product to do the right thing.
With the right business case.
But I can't impress upon you enough about how important it is when you're trying to sell stuff. You've got to have a red-hot business case. Jazz, concluding thoughts.
Okay, I'll try and end on an upbeat note as well. So yes, NHS and social care are pretty much kind of on their knees right now, but there is hope out there. And I think some of that is looking at things from a completely different way. So off the top of my head, one of the stats that's always stuck out to me, and this is from an investment perspective, so for any suppliers out there who are trying to come up with new technologies, 2% of global funding goes to minorities of any sort. That is female founders who are people of colour from the LGBTQ+ community, or they have a learning or physical disability of some sort. They outperform their peers by about 30%. So when you're looking at products, women's health, for example, is considered niche. They make up 51% of the population. They are not niche. They are a massive product market for you. They are a massive resource for you. And I would recommend to anyone who is coming up with anything to do with technology, read a book called Invisible Women by Caroline Criado Perez. She identifies all of the different ways that there are data gaps in literally like every aspect of our society, how you build products, how you build policies, how you build change management, anything and everything. I think it's probably one of the most transformative books I've ever read, and I would 100% recommend that to every supplier, because there will be data gaps in the tech and the data that you currently have. So just bear with me, I'll be quick about this. In social care, we often have suppliers who come and pitch to us and say, we've got AI who does this and AI who does that, and it's great, right? But my first question, or one of my first questions to them is, how have you desegregated that data? What are those data data sets built on? Are they built on existing data sets, which are mostly of white men, or are they data sets which are inclusive of everyone? And so I think technology has a lot of potential. I think there's a lot of innovation happening. I think more funding needs to be given to it. I think there's alternative sources of funding that are being looked at. Like people, suppliers are looking at getting VC-backed funding rather than waiting for the NHS, for example, or social care. And for people who are looking at solutions that they think that don't work in the NHS because the NHS has tons of bureaucracy, or it takes too much time to make a decision, or they don't have the money, a lot of those solutions probably will fit in the social care sector as well. Go speak to that market. It's there.
Thank you for that. And what was the name of the book again? Tell us the name of the book. Make sure everybody's...
It's called Invisible Women by Caroline Criado Perez.
Okay, so you've got to read that. And I tell you another area that, just quickly, I think there is in social care, and a lot of the, as you said, the domiciliary market particularly is a mama papa shop type of market. There's a huge market there to lift all the back office costs off of those organisations and consolidate it somewhere with some kind of online tool service, you know, that does the training, the recruitment, the wages and the whatever. You could lift the back office costs very easily. It's simple software to do, and it would give people time to get on and do their business. I don't know why there's not been that consolidation, because it's crying out to be done. Liz, you got 30 seconds to send us home with a happy tune.
Okay. It will happen. So I remember being taught how to type an email when I was working clinically. That was revolutionary. Now we use it all the time. I also remember when electronic health records first came in. Now it's invitations to tender all day long. It's part of the infrastructure. This will happen. For suppliers, the challenge is getting there and staying alive to get there. The other final thing I want to say is when we talk about the UK, and I said this to you earlier, we quite often reflect what's happening in England, but don't forget Scotland, Wales and Ireland, they have different strategies and different approaches. So as a supplier, go and make sure you go to the full UK market.
Very good. And John, the last word with you, with 8,500 voices. Send us home happy.
It's not an impossible dream. We have 42 integrated care boards. I'm talking about in England now. We need visionary leadership who can act in an inclusive and consultative manner amongst the people who've got opinions and experiences to share. And I think if we get good leaders who have the ability to bring those cohorts together in a spirit of positivity and doing the right thing for the citizens, then absolutely it can happen.
There you go.
But we need a different language and mindset.
You've heard it here first. I just want to say, I'm right up against the buffers of time. It's 5 o'clock. I just want to say thank you for coming to Giant. Have you enjoyed Giant? Yeah? You're going to come next year? Yeah? That's good. Have you enjoyed this session? Then please say thank you to our excellent panel. Thank you very much. Thank you for coming. Have a safe journey home, and we'll look forward to seeing you next year. Thank you very much.